Positioning Lesson 7 covers the knee and patella, one of the most heavily tested positioning areas on the ARRT. The knee requires a cephalic angle on the AP, the lateral requires exactly 90 degrees of flexion, and several special projections have very specific clinical indications. 13 minutes. AP knee. Patient supine, leg fully extended. Both epicondyles equidistant from the IR, no rotation. CR, 5 to 7 degrees cephalic, toward the head. That angle is not arbitrary. The tibial plateau slopes posteriorly approximately 5 to 7 degrees. A perpendicular CR would strike the tibial surface obliquely and close the joint space. The cephalic angle aligns the beam parallel to the tibial plateau, opening the joint space and allowing accurate assessment of the medial and lateral compartments. Center, 1/2 inch below the apex of the patella. KVP, 60 to 70. Ishi, 40 inches. No grid for most patients. Evaluate both compartment joint spaces, tibial spines, intercondylar notch, and fibula head position. Lateral knee, lateral recumbent, affected side down. Knee flex 20 to 30 degrees. The slight flexion relaxes the posterior capsule and opens the patellofemoral joint space. CR, 5 to 7 degrees cephalic, opens the femorotibial joint. True lateral. The femoral condyles must be superimposed. Any separation indicates rotation. Evaluation on lateral. Patella visible in profile. Patellofemoral joint space open. Blumensaat's line assessment. At 30 degrees of flexion, the inferior pole of the patella should align with the roof of the intercondylar notch. Patella alta is high above the line. Patella baja is low below it. 2 oblique projections. Medial oblique. Internal rotation 45 degrees. Demonstrates the lateral tibial condyle and the fibula head in profile without superimposition on the tibia. Lateral oblique. External rotation 45 degrees. Demonstrates the medial tibial condyle and the tibial spine. CR. Perpendicular for both obliques, 1/2 inch below the patellar apex. Intercondylar fossa. PA axial, Camp-Coventry. Patient prone, knee flex 40 to 50 degrees. The CR is directed perpendicular to the tibia, which means angling at 40 to 50 degrees caudally from vertical. This projects the beam through the intercondylar notch. Demonstrates loose bodies in the notch, osteochondral defects, tibial spine fractures, and notch stenosis. The primary view ordered when AP and lateral do not explain the patient's symptoms. Holmblad view, patient kneeling, CR perpendicular to the joint. Alternative to Camp-Coventry for the same anatomy. For patella views, PA patella, patient prone, leg fully extended. The patella is in direct contact with the IR, minimizing OID and improving sharpness. CR, perpendicular to the popliteal crease. The knee must not be flexed. Flexion presses on an injured patella and causes pain. The PA position reduces OID compared to an AP patella, which improves detail. Lateral patella, lateral recumbent. Knee flexed only 5 to 10 degrees. CR, to the medial knee at the level of the patella. Demonstrates patellar fractures in profile and Blumensaat's line. Patella alta and baja are assessed here. Sunrise, merchant. Patient supine, knees flexed over the table edge at 45 degrees. CR, perpendicular to the IR, angled 30 degrees below, horizontal toward the feet. Demonstrates patellofemoral alignment, the trochlear groove, and patellar subluxation. The primary view for patellofemoral syndrome and chondromalacia patella. Seti-gast, tangential. Patient prone, knee maximally flexed, 90 to 115 degrees. CR, perpendicular to the patellofemoral joint. Produces a sunrise-type view. Do not use with suspected fresh patellar fractures. The positioning is painful and risks displacement. 5 pathology signs. The registry tests, each one. Lipohemarthrosis. A fat fluid level visible on a horizontal beam lateral knee. Fat from bone marrow floats on top of blood in the joint space. This horizontal interface is only visible when the beam is horizontal, cross-table lateral. Any lipohemarthrosis indicates an intra-articular fracture that has open communication with bone marrow. The most common cause, tibial plateau fracture. Blumensaat's line. On the lateral knee with the knee at 30 degrees of flexion, the inferior pole of the patella should align with the roof of the intercondylar notch. Patella above equals alta, below equals baja. Medial compartment narrowing. On weight-bearing AP, medial joint space narrower than lateral means medial compartment osteoarthritis, the most common form. Subchondral sclerosis, osteophytes, and varus deformity accompany it. Weight-bearing views are essential. Non-weight-bearing films underestimate the degree of narrowing. Tibial plateau fracture may be subtle on AP. Look for cortical disruption, horizontal fracture line below the articular surface, or asymmetric joint space. Best confirmed with lateral and CT, classified by the Schatzker system from 1 to 6. Pellegrini styida lesion. Calcification adjacent to the medial femoral condyle at the MCL origin. A post-traumatic finding after an old MCL injury. Incidental finding on the AP knee, dense opacity medially. No treatment required unless symptomatic. 3 knee and patella questions. The answer is C, to compensate for the natural slope of the tibial plateau and open the joint space. The tibial plateau slopes posteriorly approximately 5 to 7 degrees. Without the cephalic angle, the beam strikes the surface obliquely and the joint space appears closed or foreshortened, making compartment assessment unreliable. The cephalic angle aligns the beam parallel to the plateau, projecting the joint space open. This is especially important for detecting cartilage loss and compartment narrowing. The answer is C, PA axial, Camp-Coventry, knee flex 40 to 50 degrees. This projection is specifically designed to project the beam through the intercondylar notch. The patient is prone, the knee is flexed 40 to 50 degrees, and the CR is angled caudally perpendicular to the tibia. Loose bodies and osteochondral defects that are hidden by the condyles on AP and lateral views become visible here. The answer is B, lipohemarthrosis, indicating an intra-articular fracture. A horizontal fat fluid interface in the suprapatellar bursa on a cross-table lateral represents fat from bone marrow floating on blood in the joint. Because fat is less dense than blood, it rises to the top. This finding is only visible on a horizontal beam lateral, not on a standard lateral. Any lipohemarthrosis mandates further evaluation for occult tibial plateau or other intra-articular fracture. Lesson 7 complete. You covered AP and lateral knee with the cephalic angle rationale, medial and lateral oblique projections, the intercondylar fossa Camp-Coventry view, PA and lateral patella, merchant and setigas views, and 5-knee pathology signs, lipohemarthrosis, Blumensaat's compartment narrowing, tibial plateau fracture, and Pellegrini styida.